of this short presentation is to help you clerk a patient with acute appendicitis. Please pause the video now and complete the pre-test questions. The appendix is usually located on the posterior medial wall of the cecum, 2 centimetres below the ileocecal valve, explaining its usual presentation with right iliac fossa pain. This screen gives an overview of the topics presented during the course of this presentation. In particular, there'll be a focus on some clinical reasoning strategies which can be useful to improve the diagnostic approach to acute appendicitis. In terms of etiology, appendicitis usually affects people in their second and third decade and causes up to 80,000 admissions to hospital per year in the UK. In terms of pathophysiology, firstly, there is obstruction of the blind-ended tube, followed by swelling and edema, infarction and necrosis, particularly as the appendicular artery is an end artery, and then infection, most commonly with bacteria such as E. coli. It's important to consider the differential diagnosis for right iliac fossa pain, which can be categorised into bowel-related causes, renal tract pathology, and gynecological pathology. In terms of bowel-related causes, the most important ones are listed here. Next, renal tract pathology, and pyelonephritis is the most likely mimic with fever and abdominal pain. In women, gynecological pathology must always be considered, and of these, of course, ectopic pregnancy is the most dangerous and should always be excluded. Next, we look at how the diagnosis of acute appendicitis might be initiated, how a patient might present to you. The typical presentation doesn't usually present a huge diagnostic conundrum. It will be a young person presenting with typical migratory abdominal pain from central colic to sharp right iliac fossa pain associated with symptoms of systemic illness such as fever, loss of appetite, nausea and vomiting. More challenging are patients who present atypically. There are 3 groups to consider here. Firstly, pregnant women. The most common reason for non-obstetric abdominal surgery is appendicitis, usually presenting in the 2nd trimester. As the uterus grows, it will displace the appendix, and appendicitis may present as right upper quadrant pain in these women. Children can also be diagnostically challenging. They may present purely with irritability and possibly some change in bowel habits such as diarrhoea. They may be less able to express their symptoms to elicit a classic history of migratory abdominal pain. And they do suffer commonly from non-surgical mimics such as gastroenteritis or mesenteric adenitis. Fever in combination with rebound tenderness in the right iliac fossa are the most reliable clinical signs. Elderly patients may also present atypically with an insidious onset and may also present more unwell with sepsis and hemodynamic instability, and always consider the possibility of an underlying malignancy in this group. The anatomical location of the appendix is usually retrocecal. However, if the anatomical location is different to this, then it may give rise to different symptoms. In the extreme case, a complete situs inversus would give left iliac fossa pain when the appendix becomes inflamed. Equally, the appendix may be pelvic, giving urinary symptoms, or retroileal, giving ureteric or testicular irritation. Next, we look at the refinement of the diagnosis, using these clinical reasoning strategies to decide how likely appendicitis is. This just gives a brief overview of the history, examination and investigations phase. Do pause the video to look more thoroughly at the sheets. For the history of presenting complaints, Socrates is very helpful to determine more about the nature of the pain. And it's also important in this phase to consider the patient's concerns and any ideas they might have. Systems review is very important to ask about urinary symptoms and gynecological symptoms in women and to conduct a malignancy screen. Red flags should also be thought about at this point in the history, thinking about whether there's anything which is suspicious of an atypical underlying diagnosis. Next are listed the other important parts of the history. For the examination phase, the purpose of the peripheral examination is to establish if the patient is well or unwell. When examining the abdomen, it's important to establish, is this appendicitis? Could it be? Or is it more likely to be something else, based on whether the pain is located in the right quadrant of the abdomen at McBurney's point, and also whether there's any evidence of perforation giving rise to rebound tenderness. There are some clinical eponyms which it's worth being familiar with. In terms of initial investigations, urinalysis and beta-HCG in women will be essential. The blood tests as listed here. The role of imaging is discussed further in the following slide. Throughout this assessment phase, consideration should be made to the Alvarado score based on history, examination and investigations findings to define the probability of appendicitis in your patient. Moving on to defining the final diagnosis, which is often at surgery, but it may be that further tests are required. This management algorithm is helpful. In unstable patients, it might well be that a CT is appropriate, followed by theatre if indicated. In stable patients, in males with a clear diagnosis, they can proceed without imaging directly to theatre preparation and diagnostic laparoscopy. In females, ultrasound is always the first line imaging to exclude gynecological pathology. If the ultrasound is uninformative, they may also need to have diagnostic laparoscopy. For the junior doctor on the ward, patients with a possible diagnosis of appendicitis can be divided into three groups. Those for immediate surgery, those for inpatient watchful waiting, and those for immediate discharge. Preparation for surgery is fairly standard, and the important points are listed here. And starting perioperative antibiotics is recommended. For inpatient watchful waiting, it's essential to regularly review the patient and establish any evolving clinical picture, and to examine their abdomen regularly as part of this. For those who are discharged, they might well need analgesia, but also safety netting is very important, seeing as appendicitis is not ever completely excluded in this group. It may be that their symptoms will continue to evolve. That completes this overview of the diagnostic approach to acute appendicitis. You may wish to pause the video now and complete the post-test questions.